So we move on to the next. I call upon the presenting author, Dr. Akanksha Prabhu, to present the case report of retinopathy of prematurity with glaucoma.
Good afternoon everyone. Today I will be presenting a case on ROP with glaucoma. So as we know, ROP is a potentially blinding disease affecting the retinal vasculature of preterm babies and is emerging as an important cause of childhood blindness worldwide. Management of advanced stages of ROP include laser photocoagulation, intravitreal anti-VEGF, scleral buckling, lens-sparing vitrectomy and lensectomy plus vitrectomy. Glaucoma is a well-recognized complication of ROP that may be associated with immature development of anterior chamber, ROP itself or as a complication of ROP treatment. There have been various cases reported where ROP treated eyes have shown shallowing of anterior chamber due to pupillary block or due to synechiae. So this complex etiology of glaucoma in patients with ROP emphasizes the importance of glaucoma screening in both short-term and long-term cases in treated and untreated eyes. So the aim was to report a case of a 4-month-old male infant with zone 2 stage 4A ROP associated with glaucoma. The baby was born at a gestational age of 32 weeks 1 day via LSCS in view of antepartum hemorrhage and he weighed 2 kilos. He had a weak cry with a heart rate less than 100 beats per minute and was hence kept on bubble CPAP with 30% FiO2 and 6 PEP for 8 days. On routine ROP screening, he was diagnosed to have both eyes zone 2 stage 4A ROP, for which he underwent right eye lens sparing vitrectomy plus endolaser followed by left eye panretinal photocoagulation. On subsequent follow-up, mild corneal haze was observed in the right eye, for which IOP was 38 and 12 mm Hg in the right and left eye respectively. Other parameters were Y to white was 12 mm in the right eye, axial length 23.38, ACD of 3.21, whereas left eye had an Y to white of 11 mm, axial length of 19.5 and ACD of 3.10. Fundus examination was normal in both eyes. Gonioscopy under sedation showed peripheral anterior synechiae superiorly and temporally, and Schwalbe's line was seen in the nasal and the inferior quadrant. Left eye gonioscopy was normal. Therefore, the child was started on dorzolamide plus timolol, 1 drop right eye BD, and he underwent right eye combined trabeculotomy and trabeculectomy under GA. Intraoperatively, after the eye was cleaned and a speculum was inserted, a limbal-based conjunctival flap was raised. 4 by 5 mm was marked on the sclera and a partial thickness scleral flap was created, following which the Schlem's canal was identified, a radial incision was placed and a trabeculotomy was done, following by which trabeculectomy and iridectomy was done. The scleral flap was sutured with 10-0 ethylon, cornea of the conjunctiva was sutured with Vicryl, and then the eye was patched. Postoperatively, the child was noted to have an IOP of 10 and 12 mm Hg in the right and left eye respectively, and he was started on tapering doses of antibiotic steroids. Subsequent follow-up, IOP was within normal range and the child had a stable retina. So treatment of ROP has known complications such as cataract inflammation, vitreous hemorrhage, retinal detachment and glaucoma. So the pathogenesis of glaucoma and ROP has various proposed mechanisms, including the incomplete development of the anterior segment and angle closure. It is attributed to pushing of the lens iris diaphragm forward by the retrolental tissues as well as pupillary block or neovascularization. In this case, it is quite possible that the underdevelopment of the anterior chamber as well as the ROP may have put the child at an increased risk of glaucoma, which was then exacerbated after vitrectomy. Hence, a careful anterior segment examination in ROP must be done to rule out glaucoma risk factors. In conclusion, the multifaceted complications associated with ROP and its treatment, particularly the heightened risk of glaucoma, highlight the importance of vigilant monitoring. By better understanding this intricate relationship, ROP and its complications, healthcare providers can better navigate the challenges in managing these vulnerable patients. Thank you.
Why do you think only one eye developed glaucoma?
It's quite possible, maybe because after the vitrectomy he developed a glaucoma, like an angle closure glaucoma. So the lens in the pediatric age group, the lens is more spherical. So maybe there was a pupillary block, but
How do you, trabeculotomy is useful here? Already PAS, you said gonio, there was PAS.
PAS, yes ma'am. So generally you also get trabecular dysgenesis along with an angle closure, so that's why we went ahead with the trabeculotomy and the trabeculectomy.
So this is not a primary glaucoma,
It's not a primary glaucoma.
We call upon the next presenting author, Dr. Joshi. She will be presenting on correlation of intraocular pressure with central corneal thickness in premature and full-term infants.
Good afternoon, everyone. Thank you for giving me the opportunity to present. My topic of presentation is intraocular pressure and center corneal thickness in preterm and full-term newborns in tertiary health care center of rural India. Coming to introduction, there is a fluid pressure inside the eye which is known as intraocular pressure. Intraocular pressure is maintained through the delicate balance between aqueous humor production and its drainage through the trabecular meshwork. In context of glaucoma diagnosis and management, the clinical significance of center corneal thickness is well acknowledged. Measuring the intraocular pressure is crucial for diagnosing and treating optic nerve disease. CCT is a factor that impacts the measurement of IOP and should be taken into account when interpreting IOP result. Higher the CCT, falsely high the IOP and vice versa. Congenital glaucoma is characterized by elevated intraocular pressure with alteration in the optic nerve head and structural abnormalities of the eye. Premature neonates have higher CCT as compared to the full-term newborns. This thickness gradually diminishes over the time. There has been gradual decrease in intraocular pressure along the CCT. Material and method. This study is a prospective observational study and it was done in Pediatric ward and NIC of Pediatric department, and study duration is for 1 year. Total 50 premature and full-term newborns are taken in study, and IOP measurement was done by tonopan and CCT measurement was done by ultrasonic pachymeter. Patients were divided into two groups, Group A and Group B. Group A consists of premature newborns with gestational age less than 37 weeks, and Group B consists of full-term newborns with gestational age more and equal to 37 weeks. Inclusion criteria include the patient with admitted in pediatric ward and NICU with gestational age less than 37 weeks for premature infant, and for term infant gestational age equal to or more than 37 weeks. And patient attendant who are interested in participating in the study. Exclusion criteria includes corneal and iris alterations, congenital cataract, ROP, congenital glaucoma, and patient with major organ dysfunction or a syndrome, or with the factor possibly affecting the IOP, like patient on mechanical ventilation or pulmonary or circulatory complications. This is the chart for premature and full-term newborns. Total 29 premature newborns are included in the study, and 21 term newborns were included in the study. Result: the mean age of measurement was 33 plus minus 2.1 week for preterm newborns and 38 plus minus 2 weeks for term newborns, and comparison was statistically significant, p-value less than 0.01%, and the mean birth weight was 1578 plus minus 324 grams in premature, and for mature it is 2.8 gram, and the mean intraocular pressure was 19 plus minus 3 for premature, and for term newborn it is 17.4 1 plus minus 2.4 millimeter of mercury, and it was statistically significant. And CCT was also statistically significant with values in 589 plus minus 35 millimeter in premature and 568 plus minus 25 millimeter of with millimeter in micrometer, in full term newborns. This is the table depicting the same. Coming to discussion, there is limited amount of data is available on center cornea thickness of preterm and full term children during the neonatal period. Hence, the present study was conducted among 50 patients to assess the correlation between the center cornea thickness and intraocular pressure. Measuring IOP is the crucial evaluation for diagnosing and treating the glaucoma. The measurement of IOP is a crucial indicator for diagnosis and treatment of ocular hypertension, refractive error, and newborn glaucoma. So take home message is in premature newborns, IOP measurement was slightly greater than full term newborns because of increased CCT. Low birth weight appears to be distinct and separate factor contributing the higher CCT. Cornea thickness decreases as the individual ages and the reaches at the level comparable to the full term newborns after some time. In eyes without other glaucomatous alterations such as with higher IOP value cannot be considered as the pathological. These are references. Thank you.
What type of glaucoma is common in children?
I'm open and
Correct. So congenital glaucoma, it doesn't come under corneal thickness is immaterial, isn't it? So, I mean, the adult pachymetry, we correlate it for the IOP. Do you think we can extrapolate it to the pediatric group? Whenever we see a pediatric consultation, how often we check the intraocular pressure?
Rarely.
Rarely.
Intraocular pressure.
Yeah.
That's
But
why
it's a nice observation that there is a difference in the thickness in the cornea of the preterm and the full term.
even in full term newborns, center cornea thickness is slightly high as compared to the adult population. It is 568 in our study.
Agreed. I mean, it's an observation, agreed. But I mean, like a practical application is this is what.
Yes.
Which stats you utilize for this?
Yes, ma'am.
Which statistical test you utilize for this?
Which statistical test you utilize for comparison?
Ma'am, t-test.
Which t-test? No, you don't know.
So move on to next.
Yes, okay.
So we move on to next.
Thank you.
I call upon Dr. Nisha Yadav.